Mobilization and relaxation techniques are effective in treating dysfunction of the motor system. This holds as much for the spinal column as for the extremities. It does not mean, however, that these techniques cannot be applied to patients with structural lesions such as arthrosis, as long as they are painful and impair normal function. If we are able to improve function in spite of changes in structure, then pain is usually also relieved. These techniques affect both joints and muscles, especially where movement is pathologically limited. The basis of every therapeutic method is proper examination and diagnosis. We begin with inspection, looking for any asymmetry, assessing trophicity, in particular of muscles, possible muscular wasting, and the shape of joints with possible deformity. By palpation, we examine tissue and muscle tonus, and we look for myofascial trigger points. We also palpate joints for deformity, for altered structure and crepitation during movement. The most important function is movement, which can be both restricted as well as exaggerated. We examine active movement, resisted movement, and passive movement. Active movement is the result of muscle and joint function. By resisted movement, we examine muscle function. We have to distinguish concentric, eccentric, and isometric resistance. The latter prevents any movement. Passive movement is most complicated and most important for diagnosis. It may look as though we examine passive structures in particular joints. This, however, is not true, because the muscles are not only the motor, but also the brakes of movement, as can be seen from the examination of eccentric movement. Here, for example, we can see how the gastrocnemius muscle limits movement in the talocrural joint. This becomes very clear when studying the barrier phenomenon. Examining passive joint movement, there is a range of movement where no resistance can be felt. From a certain point, however, resistance increases gradually until it cannot be overcome. Normally, we distinguish the anatomical and the physiological barrier. The anatomical barrier is made of bone and can never be reached in the living. It is protected. The physiological barrier is reached when we can feel the first minimum resistance. It can be overcome easily. It springs. If function is disturbed, we diagnose a characteristic pathological barrier. It restricts movement, does not easily give, and springs very little. It can be found in one or several directions. It can even cause a change in the neutral point, producing asymmetry of movement. Therefore, asymmetry is a cardinal sign of disturbed function. The barrier has a protective function, guaranteed by the soft tissues, by the muscles in the first place. If the cause of dysfunction is inside the joint, we find a pattern of movement restriction which is characteristic for each joint, the capsular pattern, according to Cyriax. If restriction is found in several directions, its proportions are characteristic for every joint. Thus, it is characteristic for the elbow and/or the knee joint that flexion is more and earlier affected than extension. If this proportion is not found, the cause is not in the joint. It is important to distinguish two types of movement: function movement and joint play. Function movement is the term used for active movement, i.e., movement which can be performed by muscular activity, for example, finger flexion or extension. Joint play is movement which is possible only passively. In the case of our fingers, it is translatory movement, i.e., dorsopalmar or lateral-lateral, rotary, and distraction. This is particularly important for mobilization. If function movement is painfully restricted, joint play in any direction is pain-free and gentle, therefore much more suitable for mobilization, as can be seen from the diagram. In this way, free sliding of the joint facets is restored. This is also true for distraction, which is particularly gentle, and which can be easily combined with translatory movements. Disturbed joint play, as well as impaired function movement, can be diagnosed by the barrier phenomenon. Up to a certain point, very little resistance can be felt. Then, beyond this point, it starts increasing. As long as this is physiological, the barrier is soft and easily sprung. The pathological barrier, on the other hand, springs very little. Thus, a hard resistance can be felt. The diagnosis of disturbed joint play is particularly important because it can be made much sooner than that of restricted function movement. This also implies that normal joint play is a prerequisite of normal function movement. Because the joint facets are not usually straight but have the shape of a joint head and a cavity, the translatory movement is not symmetrical according to Kaltenborn. If we fix the convex partner in the joint and mobilize the concave partner, translatory movement is mainly in the direction of function movement. If, however, we fix the concave partner, translatory movement takes place in the opposite direction to that of function movement. For therapy, we first have to engage the barrier by taking up the slack with minimum force. Then it is essential to wait and make sure that the patient has relaxed. We then have several possibilities. We can normalize the pathological barrier by repeated gentle springing. We can also just wait for release, in which case it is best if the patient first activates the muscle against slight resistance, followed by post-isometric relaxation. Relax. Pull in the thumb against me. Hold it. Hold it. And now relax again. After engaging the barrier, we may deliver a thrust, temporarily disrupting the barrier and causing temporary hypermobility. And finally, wherever this is possible, we may apply fast shaking in the spontaneous rhythm of the structure. With post-isometric muscle relaxation, the range of motion in the joint increases too. This shows the close relation of joint and muscle dysfunction, which is in full agreement with the barrier phenomenon. With post-isometric relaxation, The first step is again to take up the slack in the direction which is opposite to the muscle's activity. If, for example, a trigger point is in an adductor, we take up the slack into abduction. The patient is then asked to contract his muscle with a minimum force, in our case into adduction, and we resist him isometrically for 5 to 10 seconds, after which he is asked to let go. After a short latency, relaxation takes place and the range of movement increases spontaneously as release is obtained. We must feel the relaxation and must not interrupt it before it is complete. As long as we feel relaxation is continuing, we just wait. It may take 10 seconds and even longer. The longer the better. We may call it melting away. If, however, relaxation is not satisfactory, we repeat the procedure from the position we have gained by the first attempt until we have normalized the barrier. This can be assessed by comparison with the opposite side and checking that the trigger point has vanished. The most frequent mistake is to not wait long enough before relaxation begins and to stop it before it is complete. The worst mistake, however, is for the therapist to stretch. We can never relax the patient. Only the patient himself can relax. Stretching will invariably produce the stretch reflex and prevent relaxation. Whenever possible, we make use of gravity. The technique is called gravity-induced relaxation, according to Jocelyne. It helps to avoid technical mistakes. It has the advantage of being self-treatment from the start. For example, when treating biceps, the patient lifts his forearm by flexing his elbow for several centimeters for 20 seconds and then lets it drop for another 20 seconds, relaxing. This he can repeat 2 or 3 times. Post-isometric relaxation is combined with reciprocal inhibition. It was widely believed that to obtain good results, maximum force was needed. This easily resulted in something like a struggle between the patient and the therapist, which is most undesirable and quite unnecessary. With a repetitive movement against slight resistance in the direction of the previous post-isometric relaxation, we can achieve the desired result. For self-treatment, the patient can also make a maximum movement in the direction of the relaxation with considerable force and hold it for several seconds. In this way, the antagonists of the muscle relaxed are stimulated, inhibiting the muscle containing the trigger point in a reflex way. For greater effect, it is useful to combine post-isometric relaxation and reciprocal inhibition. Important technical advice. The patient must be in a comfortable position in which he can relax. The structure to be treated, i.e. muscle or joint in particular, has to be relaxed. The therapist must also be relaxed. He must therefore be in a suitable position and should adapt the treatment table accordingly. When performing joint mobilization, as a rule, one hand has to fix usually the proximal part of the extremity, while the other mobilizes, usually the distal part. The therapist's mobilizing forearm should be parallel with the direction of mobilization. The hands or fingers of the therapist should be close to the articulation to prevent leverage, but far enough away to prevent joint compression. The hands or fingers of the therapist should be firm and yet gentle. This implies making contact with as broad a surface as possible. Never use the tips of your fingers, and when fixing the proximal part of the extremity, use the palm of the hand. We repeat. The first step in diagnosis is to approach the barrier gently with minimum force and then spring it swiftly but not forcefully, and never to go back from the barrier. The springing movement starts from the barrier. There should always be a little pause between taking up the slack and springing. The first step in therapy is the same. First, engaging the barrier, i.e., the point where we feel the first minimum resistance. We must then wait for release, which has to be followed to the end. Alternatives being repetitive springing, fast shaking, or thrusting. The interphalangeal joints. Function movement is palmar and dorsal flexion. It can be adequate, restricted, or hypermobile. Mobilization and diagnosis of joint play of these joints illustrates the principles given earlier. The patient is seated comfortably. The therapist stands or sits by his side and grasps the proximal phalanx between the thumb and forefinger of one hand, and in the same way grasps the distal phalanx with the other hand, close to the joint. Because in this case, the proximal phalanx always has to be fixed, the therapist's hand must be supported on his own body or on a firm object, while diagnosis and mobilization are carried out by the other hand, exclusively in the direction of joint play. Mobilization is possible by distraction and by translation in a dorsopalmar and in a lateral-lateral direction. It is very advantageous to combine translatory mobilization with distraction. The direction of translation determines the position of the therapist's fingers. If mobilization is intended in a dorsopalmar direction, the phalange have to be grasped on their dorsal and palmar surface. If, however, mobilization takes place in a lateral-lateral direction, they are held on either side. The technique is the same between the first and second, and between the second and third phalanx. The second to the fifth metacarpophalangeal joints. Although these are ball and socket joints, function movement takes place only in a dorsopalmar and lateral-lateral direction because there are no muscles with a rotary function. In these joints, there is frequent hypermobility. Joint play is in distraction and translation, which can be dorsopalmar, lateral-lateral, and also in rotation. Here, too, we recommend combining mobilization with distraction. With one hand, we fix the patient's palm from the ulnar aspect for treating the third to fifth finger, from the radial side for the index. The mobilizing hand grasps the proximal phalanx between the thumb and forefinger, and with the little finger round the third phalanx for traction. Thrusting these joints into traction with slight flexion can be most useful, in particular as first aid in slight distortions, such as occur in volleyball. The fixation is the same as in the previous techniques, but here the forefinger forms a fulcrum on the palmar surface of the first phalanx, while traction is carried out by the little finger on the third phalanx. After engaging the barrier, the thrust takes place into traction with flexion. These techniques can also be used for self-treatment. The patient supports his hand on his trunk or thigh or a table and grasps the first phalanx of the finger to be treated between his thumb and forefinger with the little finger round the third phalanx. He can mobilize in a translatory or rotary direction under traction, or can even use his forefinger as a fulcrum to thrust the joint into traction with flexion. The carpometacarpal joint of the thumb. This joint suffers frequently from overuse by pressure on the thumb, causing pain and arthrosis. Diagnosis of movement restriction and mobilization aims at the articulation between the first metacarpal and the trapezium. For this, we have to fix the trapezium between the thumb and forefinger of one hand and with the other hand the first metacarpal, so as to take up the slack and to spring the joint, to diagnose joint play, and for mobilization. The patient is seated and we stand or sit at the ulnar aspect of his hand. We have first to locate the trapezium with our thumb and forefinger. One way of doing so is to find the end of the radius and then to move towards the thumb. The end of the radius is relatively wide and the scaphoid is narrow. Then the trapezium is wider again and has to be fixed between the thumb and the forefinger. This hand must be supported. With the other hand, we grasp the first metacarpal close to the joint and the end phalanx with the little forefinger. Now we can make translatory movements combined with traction using the little finger at the end phalanx of the thumb. Translatory movements can be carried out in a dorsopalmar and in a lateral-lateral direction. For this, we have to place our fingers accordingly. For diagnosis by traction with the little finger, we take up the slack in the direction of translation and spring the joint. For mobilization, we use slower, repetitive springing. An alternative is to use traction only, which is particularly useful for self-treatment. The therapist stands at the ulnar aspect of the patient's hand, which is held in pronation. He grasps it with his hand pointing in a distal direction. He puts the little finger of his other hand round the end phalanx of the patient's thumb and grasping the first metacarpal with his thumb and forefinger. This acts as a fulcrum close to the saddle joint. He then exerts a pull into traction and flexion to take up the slack. After this, we can tell the patient, resist the pull with minimum force. Hold it for 5 to 10 seconds, and let go, relax, waiting until we feel release. This can be repeated. We may also deliver a thrust after engaging the barrier. This maneuver is followed by distraction in a dorsal direction. We grasp the patient's hand, which is held in supination. The little finger of our other hand is round the distal phalanx of the patient's thumb. Our forefinger acts as the fulcrum just above the carpometacarpal joint. By a slight traction, we engage the barrier. Now the patient resists traction slightly for 5 to 10 seconds, followed by relaxation. Mobilization can also be achieved by repetitive springing. Or after engaging the barrier, we can apply a thrust in the direction of distraction and dorsal flexion. For self-treatment, the patient fixes his forearm held in pronation against his trunk. With the little finger of the other hand, he grasps the end phalanx, and with his thumb and forefinger the first metacarpal close to the joint, where the forefinger serves as a fulcrum. Using this fulcrum, he exerts a pull into traction with flexion to take up the slack, and may now resist this pull with little force for 5 to 10 seconds, followed by relaxation and release. He then turns his hand into supination and carries out traction in a similar way, with his little finger around the end phalanx and with his thumb, using the forefinger as a fulcrum, on the dorsal aspect of the joint, giving him the choice of post-isometric traction or a thrust in a dorsal direction. Another possibility is fast shaking into traction. The patient is supine. With one hand we stabilize the affected arm above the elbow. With the other we grasp the first metacarpal. After taking up the slack by slight traction, shaking traction follows at the spontaneous rhythm of this structure. The same can be done with the hand in supination. This, too, can be used for self-treatment. The most frequent trigger points are found in the short thumb adductor, in the opponens pollicis, and in the abductor of the little finger. Relaxation of these muscles is easy, effective, and self-treatment easy as well. The short thumb adductor. Trigger points can be palpated between the first and second metacarpal bone. Treatment. With one hand we fix the patient's hand, and with the thumb of the other we abduct his thumb to take up the slack. The patient is told, "Press very slightly against my thumb. Hold it, and now relax." This can be repeated 2 or 3 times, always from the newly reached position. For reciprocal inhibition, the patient exerts pressure against our repetitive resistance, or he exerts strong pressure into abduction. Self-treatment is similar. The patient fixes his hand against a support, and with the thumb of the other hand abducts his thumb to take up the slack, then resists abduction with a minimum force for 5 to 10 seconds, and relaxes into abduction. After a few repetitions, he maximally abducts the thumb, or does so repeatedly against resistance by the other hand. The opponens pollicis forms most of the thenar eminence, where trigger points can be found. For relaxation, we move the thumb first into the direction of oblique abduction to take up the slack. The patient is told, "Press against my finger. Hold it, and after 10 seconds we ask him to relax." The technique is repeated from the position we have reached by the previous maneuver. This is followed by repetitive oblique abduction, which is resisted. Self-treatment is similar. The patient has his hand supported and brings his thumb into oblique abduction by his other hand to take up the slack, followed by resistance and relaxation. This is repeated, and reciprocal inhibition follows by active movement of the thumb into oblique abduction, or the patient resists repetitive pressure against his other hand into oblique abduction. The little finger abductor. Trigger points are palpated on the lateral aspect of the fifth metacarpal. For PIR, we adduct the little finger to take up the slack. The patient is then told, "Press against my finger with minimum force. Hold it, and after 5 to 10 seconds, we tell him to let go." Press against my finger with minimum force. Hold it, and now relax. After 2 to 3 repetitions, he is told, "Press against my finger into adduction," and we resist his pressure. The repetitive reciprocal inhibition can be used as well. Self-treatment is similar. The patient supports his hand, and with his other hand he adducts his little finger to take up the slack. He then presses against this finger into abduction with minimum force, followed by relaxation. This is repeated, and for reciprocal inhibition, he adducts his little finger against resistance by his other hand or by the fourth finger of that hand. The wrist. This is a very complex articulation which is formed by the radius and the 8 carpal bones with the metacarpals. Its function is dorsal and palmar flexion and adduction and abduction. 2 joints can be distinguished, one between the radius and the proximal row of carpal bones, i.e. the navicular, the lunatum, and the triquetrum, and one between the proximal and distal carpal bones, which is formed by the trapezium, the trapezoid, the capitatum, and humatum. During palmar flexion, the proximal carpal bones move in a dorsal direction in relation to the radius. This is in keeping with joint play. The proximal row of the carpal bones moves mainly in a dorsal direction in the radiocarpal joint. Therefore, if we find restricted palmar flexion, we will mobilize the proximal carpal row in a dorsal direction against the radius. It is simplest to grasp the end of the radius with one hand, which is supported for fixation, and with the other hand to hold the patient's wrist in supination close to the radiocarpal joint. By minimum pressure in a dorsal direction, the slack is taken up, followed by springing for diagnosis. By repeated slow springing, the joint is mobilized. Self-treatment is carried out in a similar way. The patient supports his forearm against a firm object in supination. With the other hand, he grasps his wrist close below the radius. By slight pressure, he takes up the slack and springs the joint slowly in a dorsal direction. It is also possible to mobilize by a pincer movement of our thumbs and forefingers of both hands. The patient's hand is in pronation, and the therapist puts the first phalanx of his bent forefinger of one hand under the patient's pisiform and that of the other hand under the distal end of the scaphoid, and the thumb of one hand on the distal end of the radius and that of the other hand on the distal end of the ulna. By slight pressure of the forefingers against the thumbs, the slack is taken up, and mobilization takes place by rhythmic springing in a dorsal direction. Dorsal flexion of the hand takes place mainly in the intercarpal joint. It goes hand in hand with a palmar displacement of the distal row of carpal bones, mainly capitatum and humatum, against the proximal row. Therefore, joint play of the distal against the proximal carpal bones takes place mainly in a palmar direction. The simplest way to treat the mediocarpal joint is by grasping the distal end of the forearm in pronation, supported against a firm object, and with the other hand to hold the wrist at the distal end of the metacarpal bones. The slack is taken up by slight pressure in a palmar direction, and by fast springing we diagnose movement restriction. The joint is mobilized by repeated slow springing. Self-treatment is similar. The patient has his forearm supported against a firm object, in pronation, and grasps his own wrist from above just below the end of the metacarpal bones and takes up the slack by slight pressure in a palmar direction, followed by slow springing in a palmar direction. Movement in the medial, and in particular in the lateral direction, is much more complicated. One reason being that here mobility of the ulna against the radius plays an important role, which will be explained later. First, the relatively simpler medial flexion will be described. Here the entire proximal row of carpal bones shifts or slides in a lateral direction against the radius, as can be seen on inspection. Medial flexion is facilitated by palmar flexion and inhibited by dorsal flexion of the wrist. Mobilization of the radiocarpal joint can address mainly its ulnar part. It is useful to apply a pincer movement at the ulnar aspect of the joint. In diagnosis and later in mobilization, our hand fixes the distal end of the ulna by the first phalanx of the bent forefinger from the dorsal aspect, and by slight pressure of our thumb against the patient's pisiform, we take up the slack and spring. Self-treatment is identical. Another possibility is mobilization in a lateral direction. The patient's hand is on the table in pronation, slightly flexed. We grasp the distal end of the forearm with one hand from the radial aspect, and with the mobilizing hand hold the patient's hand from the ulnar aspect below the forearm. Our fingers are on the patient's palm and the thumb across the dorsal aspect of the hand. With slight pressure from the ulnar aspect, the slack is taken up and springing takes place in a radial direction. Most complicated of all is lateral flexion. At inspection, we see no shift of the hand towards the ulna similar to the shift towards the radius in medial flexion. We can see that the palm with the first metacarpal approaches the styloid process of the radius. By what mechanism can this be explained? During lateral flexion, there is dorsal flexion between the trapezium and the scaphoid, i.e., there is dorsal flexion at the radial end of the first and second row of carpal bones. This can be verified by palpation. We can feel the prominence of the scaphoid on lateral flexion of the hand on a palmar surface close to the styloid process of the radius. This mechanism of dorsal flexion also explains why lateral flexion of the hand is facilitated by dorsal flexion and inhibited by palmar flexion. The same techniques by which we restore dorsal flexion of the wrist are therefore also used for mobilization of restricted lateral flexion. We may, however, put more pressure on the lateral side of the mid-carpal joint. Mobility of individual carpal bones. The carpal tunnel is formed by all the carpal bones and the transverse carpal ligament. Its importance lies in the possibility of impingement of the median nerve with its blood vessels. The walls of this tunnel have to adapt to its contents in the course of every movement of our hands. Perfect mobility of all these structures is therefore essential, and movement restriction is a regular sign of the carpal tunnel syndrome. Mobility is examined by grasping one carpal bone of the patient between our thumb and forefinger of one hand and the adjacent bone in a similar way with the other hand. The slack is taken up by minimum pressure of one hand in a dorsal and of the other in a palmar direction, producing a translatory movement. If the patient is relaxed, there is so little resistance that it is almost impossible not to produce any movement under normal conditions. If, therefore, we do not feel any movement using minimum force, we have diagnosed movement restriction. With more than minimum force, there will always be some movement, unless there is ankylosis. It is technically important to have our fingers on adjacent bones. Mobilization between capitatum and lunatum. For better fixation, it is preferable to use a pincer movement for mobilization. For this, we reinforce the thumb and the forefinger of one hand by the thumb and forefinger of the other, placing both thumbs on the dorsal aspect of one carpal bone and both forefingers on the palmar aspect of the adjacent bone. By slight pressure of the thumbs against the forefingers, a transitory movement is produced. After engaging, the barrier mobilization takes place by slow rhythmic pressure of the thumbs against the forefingers. After this, the direction of mobilization is reversed by shifting the thumbs and forefingers to the adjacent bone. The same pincer movement can be achieved also by the thumb and forefinger of one hand only, which is useful for self-treatment, but only if the patient is capable of learning the maneuver. Traction is a simple but less specific method of treatment. The patient is seated, his arm bent at the elbow supported by his trunk or thigh in supination or pronation. He fixes his forearm just below the elbow and grasps the proximal ends of his metacarpals between his thumb and forefinger, one after the other, to produce traction at the wrist after taking up the slack, and can try slow springing or rhythmic shaking. Traction can be applied for thrusting at the wrist. This is without any risk and very effective. The patient is seated, his hand in pronation, hanging in a forward and downward direction. The therapist is in front of the patient with both thumbs on the distal carpal bone at the site of movement restriction and the palms of both hands round the patient's wrist. He takes up the slack by very slight traction in dorsal flexion. The thrust is delivered by sudden, very fast traction in the direction of the forearm. The following mistakes must be avoided. The barrier must never be lost before the thrust, and dorsal flexion must not be increased during the thrust. The shaking technique is another alternative. The distal radio-ulnar joint. This joint is in close vicinity of the wrist, and its mobility greatly influences the wrist function. Mobility of the radius against the ulna, however, depends mainly on the proximal radio-ulnar joint. During palpation, movement in the distal radio-ulnar joint is found in the dorsopalmar aspect only. A synkinetic movement into pronation and supination occurs regularly during medial and lateral wrist flexion. During lateral flexion, it moves against ulna into pronation, and during medial flexion radius moves into supination. If this synkinesis is blocked, or we try to resist it, lateral flexion of the wrist is impaired. In addition, the ulna moves slightly in a cranial direction during medial flexion, as does radius during lateral flexion. We may therefore say that in restricted radio-ulnar mobility, the styloid process of the radius impacts on the carpal bones, clinically described as radial styloiditis and/or tendovaginitis, which is also called de Quervain's disease. Movement restriction between the radius and ulna is in our experience the most frequent cause of impaired wrist flexion to both sides, in particular of lateral flexion. The most important site of this disturbance is, however, at the proximal radioulnar joint. Examination of the distal radioulnar joint is simple. With the thumb and forefinger of one hand, we grasp the styloid process of the radius and with the other hand the end of the ulna. We fix the radius and move the ulna so as to take up the slack in a dorsal direction and spring it, and then in a palmar direction and spring it, for diagnosis. For mobilization, we prefer a pincer movement. First, we may put both thumbs on the dorsal aspect of the end of the ulna, and both forefingers on the palmar aspect of the radius, and spring the joint by pressure of the thumbs against the forefingers, and then put both forefingers on the palmar aspect of the ulna and the thumbs on the dorsal aspect of the end of the radius, and spring the joint in the opposite direction. Self-treatment is possible by a pincer movement of the patient's thumb against his forefinger in a similar way.